Okay, thank you, Simon. Questions, please. Again, just put your hand up and Steph will bring you the microphone. Steph?
Judith McDonald, Wanganui Regional Primary Health Organisation. Simon, it's a bit disappointing you never rung and asked about Wanganui's perspective, because I think you'll be surprised at the start that we've made. Early last year, or could have been actually the end of last year, beginning of this year, we invited Lee Manson down from Advanced Care Planning in Auckland, because a group of champions got together, led by primary care, by the PHO, around wanting to really start making a difference around advanced care planning in Wanganui. We had the pleasure of having both hospital and primary care clinicians, GPs, physicians, ED consultant, other aged residential care, hospice present at our workshop. And we have been quietly working through, because one of the issues that you have to start with is trust. And you have to have a desire to move things from the bottom up, and I know the speaker talked about that. We have lots of tools in primary care, such as electronic records, and we have spent a lot of investment in the last 2 years with our GPs around having some really good enablers like Doctor Info and Patient Dashboard, which lend itself really well to alerting GPs in a 15-minute consult about the priorities for patients. And one of the exciting things that I learnt today is around the starting of a palliative or end-of-life register, and it's something that is doable. I think we've got to start with what we can chunk up that will work, and I think this has to come without getting caught up in the barriers of money. And one thing that we're really clear about, and certainly our new Director General made it really clear, that New Zealand has to get their head around about doing more with less money. And certainly as an innovative PHO, that is, we never start with the dollars, we start with the champions, we start with the pieces of work that we think are doable collectively. And we believe our hospital and primary care clinician movement of working together is a good place to start. I think that it is the right time, and I think I urge any of you other areas that have good trusting relationships across the continuum to just start talking together, working together, and seeing where it takes us. And it might not be the preferred option from ministerial top down, but I think you might be surprised at how well we do in the end.
So just to clarify, Judith, that was predominantly around advanced care planning?
No, we will be getting into the primary register and looking at what are the aspects that we can do within the confines of what you talked about today.
Judith, just if I could ask, in terms of your PHO, like, do you have more than one PHO in Wanganui, or are you covering all of the GPs, general practice?
Wanganui Regional has probably 99.9% of the patients, and we have a small iwi PHO that has just joined the National Māori Coalition. So that does make a basis of which to get a power base, because we have one iwi practice who are invited to be part of this clinical lead, but we have a very well-established PHO which has 4 clinical directors and a nursing director, and it's community governed. So that's the basis of which we started. So a lot of the innovative stuff that we're doing has started from the bottom up, and we have encouraged our hospital colleagues to join us, and in areas such as chronic care and renal and cancer, they are certainly part of our journey, really.
Thanks, Judith. Over here, Steph, in the middle. Come on, get a move on.
I know I need the skates.
Good morning, Joanne Edwards, Wairarapa District Health Board, Funding and Planning. I totally agree with the comment previously about the funding. If we put extra funding in here, where does it come out from there? But I believe it's more a matter of how you go about it. I can give you an example that we do run a Wairarapa-wide register for palliative care patients that is attached with additional funding for free access to GPs. It's attached to free ambulance travel if they need it, and it's certainly every GP practice knows who their patients are. I recently checked, in fact it was yesterday, about the number that we've got on the register compared with our anticipated number as per the document that's come out, and we're about 15 people short of that number. So I'm quite happy that at the moment we've still got an awful lot of work to do. Totally appreciate the tripartite approach of the DHB, PHO and Te Manga Hospice, but I think that there are examples around New Zealand that we could learn from and share.
Simon, do you have any comment?
Yeah, well, just the previous two comments, I'm not hearing about a whole of system change, and if we do this here and that there, we're again not getting a necessarily unified sort of approach to things, which is what I feel the framework offers. But also, I'm also hearing that we can do it our way, which is kind of where Mid Central's been at for a while. But as I say, we're looking at the whole of New Zealand as well, and patients crossing boundaries and hooking up with GPs across the country and actually working off the same song sheet.
Yeah, just to comment, often I think we can learn a lot from small areas who have the get up and go to get things actually happening. And while bottom up is ideal, we've had experience in the central region that if you don't have the support from the top down, if you do come to get funding, you don't get the agreement of your DHBs, well, you're not going to go anywhere really. So, but it's really good to hear how you people have got on and actually you started on the journey anyhow. Other questions?
I was just wondering if there's any value in looking at the model we have with the LCP, having a national lead office. Whilst I'd be the last to say that I quite like local, but actually that's been so supportive for us implementing LCP to have that lead in many ways, a lead to look to, but also a lead that can be top down and monitor how we do it.
Well, personally, I'd be inclined to agree.
I'm not sure how it would work.
So a bit like that model Kerry suggested, the amplified sort of approach, again with facilitators and then working with local coordinators. But again, that's a significant investment, not a lot, but it's a significant investment at the present financial time to invest in that. And it's also about, well, where are the champions first? If you don't have the champions, there's no point in trying to drive something that people aren't going to do, because Wanganui's got their thing and Wairapa's got their thing and Mid Central's got its thing, and we're not actually going there. All about that dynamic. What about aged care? I'd like to hear about aged care, whether this is seen as an imposing additional thing or a really useful tool.
Hi, Julie Hollingsworth. I'm a nurse practitioner candidate with older adults across aged care and primary health. And one of the things that you mentioned, Simon, was around the ministerial support for the advanced care planning. And that is a part of this gold standards framework. So it seems from a ministerial perspective, they've picked out a piece of it that they think might help. And the examples given by the local small DHBs are also very profound. So it seems to me that if we want to move this forward, if we had champions at a local level, that can move some of the practical things that we can do in terms of talking to each other, to start with. But also if we have champions that push the ministerial level to say, well, it's all very well to go for this advanced care planning, but how about we do this as a complete holus bolus? Because from my perspective, I work alongside a lot of GPs, I work in residential care, and I've worked in hospital settings and hospice. But some of the components of advanced care planning, for instance, require the conversations. And one of the things that I've observed is a lot of doctors have trouble with the conversations. A lot of nurses do, in fact, as well. So until we actually pull all of the threads together, we're not actually going to move forward at all. We're going to do little bits of good stuff here, there and everywhere, but we're not actually going to get the whole picture. So I think just be interested in your thoughts about whether, you do a bottom-up and a top-down, and hopefully we meet in the middle somewhere.
Well, again, I'd make the comment that the framework gives that objectivity that allows exactly either a top-down or a bottom-up and solves the problems that you're talking about a fragmented approach to everything.
We have another question, Steph.
Hi, Jenny Fowler. I'm from Wanganui. My history is actually working with the elderly. I've actually just started being involved in the Inter-Eye assessment tool. And from my perspective, there is actually a lot of stuff that we're actually now starting to look at with advanced planning, advanced directives. So if we actually get back down to the patient, which is where I'm looking at probably today, is that if a patient everybody that goes into any residential care or into hospice, need long-term funding, will actually need an Inter-Eye assessment. So there's actually a whole pile of the advanced care. So if somebody goes out of the region, if they go into residential care, if they come back into hospital, if they go to the GP, there is actually going to be a standardised part of that assessment that actually, so that everybody can actually be aware. But it's actually getting clinicians to actually feel comfortable about asking these questions. So that's something that as a trainer for the assessors that I'm actually in the process of actually going through. So for me, this has actually been a really great day to be looking at that, to ensure that the assessments that we assess for the people on the Inter-Eye, actually it is captured so that wherever that person goes, that information goes with them as well. And being electronic, it will be able to be rolled out.
So just a thought there is that I think if we were going bolus at advanced care planning, that some facilitation should be offered, particularly in terms of training people around it. And I think what we're then moving to is a changed culture within New Zealand about being far easier to talk about it. So it's out there and people know what advanced care plans are. And a fascinating poster at the advanced care planning meeting in London from Taiwan, I think it was, and it was a primary school class, or research on a primary school class, and the experiences of those children experiencing their auntie and their whatever. They're profound. Again, kids are profound in their thinking, and just how stupid we are at not communicating about stuff. And we need to bring the agenda further forward so we actually do discuss these things.
Are people aware of Inter-Eye assessment the lady was referring to? Fair few nods, okay. Other questions?
So there's some shakes of the head.
Some shakes. Do you want to explain a little?
Let me explain what I think it is, unless somebody's got a microphone that can do it far better. Jenny, have you got a microphone? I think Inter-Eye comes as a number of packages. One is for aged care, and it's about a comprehensive assessment of elder health issues that, being comprehensive, it should shake out all the applied needs that person should have. And there's obviously a transferable assessment across the country and across boundaries and settings. So yeah, there is a palliative care Inter-Eye, or is that a bolt-on?
No, it's one of the suite of tools. There's a suite of 12 tools.
Right, suite of tools, one of which is palliative care. At the moment, the ministry has purchased the elder health, is that right? Home care, thank you.